Uh, Welcome, Dr. Alka Ganesh. Madam is an eminent academician, physician, geriatrician, author of many books, and Madam has worked in many capacities and a great educator. Welcome, ma'am, for your talk on community-based healthcare of older persons. Thank you.
Thank you very much, Dr. Arun and chairpersons. And I also want to thank the organizers for calling me for this very good conference, interesting conference, and that too in Kerala. So I want to bring you all down from the microscopic molecular depths of aging to ground realities. And I'm going to be talking about how to deliver healthcare to those who are already aged and have gone past their youth. And we want to compress their misery and give them as much health as possible, um, perhaps even at a preventive stage. So, I am of the firm belief that community based models of health care for the elderly is the way forward in caring for the elderly. And I'll give you the reasons why. So, what happens? We've got all these hospitals. What's wrong with hospitals? Research has shown that when an older person gets admitted in hospital, if he went in with a Barthel index of, let us say, if you're using a 20-point scale, went in with 15 over 20, he will come out, even if he's gone in for a pneumonia, may come out with 10 over 20. His activities of daily living will be much reduced. He could fall in the hospital because of the slippery, shiny floors, which are not always meant for older people. He may go into delirium because of the unusual surroundings and the unusual people who are around him. Nosocomial infections. He goes in with one infection, comes out with another infection. And then, no matter how well you train doctors, nurses, pharmacists, there are always medication errors. So, with all these things, why do we want to put patients into hospital? We have to, definitely. But are there alternative methods of delivering healthcare? And then, when you look at the administrative aspect, there's a shortage of hospital beds worldwide. And when an older person gets into hospital, the length of stay is much more longer than for a younger person. Hip fracture for a young person will take X number of days, where an older person will be much more. The costs are high. Older people don't have that much money. Sometimes, often now we see inappropriate care. You may find a little high calcium, you chase the red herring when actually you should be concentrating on something else. A whole lot of tests. Nowadays, you all know that the PET scan has replaced a general physical examination. So the old person will find himself in a PET scanner. And then, of course, the exclusion of the family. We know that health improves with the ambience of a family atmosphere, but that is not available, not possible in a hospital. And if you look at this position statement of the British Geriatric Society, which says, our vision is for older people to receive the care that they require in a setting that is appropriate to their needs and wishes. In all localities, options should exist for older people to receive high quality care without urgent care without hospital admission. So, I want to talk about types of community based care. How do we deliver this care? There are so many models. One is the daycare center, something like a creche, you can say, for children, but a little bit more sophisticated. We could visit them in their homes, which many people are already doing. And to make the home visits much more comprehensive, we could do integrated community based care, mobile medical units, and then hospital at home. So let's get into the daycare part of it. What are the objectives? You can have curative, it could be maintenance. Curative is rehab after a stroke, maybe. Controlling a disease like hypertension or diabetes is completely gone out of control, but you caught it early, it doesn't need admission. You could perform certain procedures in the daycare center. and psychotherapy can be given. So these are all to cure new problems that may occur. It's good for maintenance. Routine checks of comorbidities. You can do a comprehensive geriatric assessment or an ICOPE screening, which the WHO is promoting. Social care and recreational. Somebody is lonely, having abuse. This is one of the types of daycare center that is very common in the metropolitan cities in India also, where it is, but it is not really available for the curative and the maintenance aspects which I have just said. And then respite care. This is something used in the USA a lot. An older person living in the family, people are working, they don't know how to keep the old person happy at home. They drop him off at a creche and, sorry, not a creche, but a daycare center, and then he can be maintained. He can be prevented from going into an old age home and live with the family and still have care in the daytime. So, what is this daycare facility? How do we organize it? So, it's a geriatrician, family physician, social worker, case manager, we'll talk about later. These people can identify those who will benefit from for this. Say somebody's diabetes, very difficult to control. Let him go to the daycare center and we'll have his tests done on a daily basis, or his blood pressure checked, or his loneliness, or he needs physiotherapy. He can have it there. 6 or 7 people together can have a community group physiotherapy. And who should man the daycare center? It can be a nurse, physiotherapist, occupational therapist, dietitian, social worker. All these people ideally should be there. And you'll see the one person who is missing there is the doctor. We do not need the doctor in the daycare service unless there's a special need. And about 10 to 15 patients can be catered for in this daycare center. And these are the kind of interventions which I was talking about: BP and blood pressure testing. For incontinence, we do something known as a voiding diary, physical therapy, diet counseling, memory testing, all those things. So, this is a daycare facility which are very few in India apart from just the social aspect. And I think members of this group who have the ability to do so must fund daycare centers and get them up and running to serve large numbers of people. Let's go quickly to the home visiting. There are some people who cannot come to the hospital because they are so, I think I should use this pointer. Yeah. So, homebound elderly. Some people who have dementia, they may not maybe be able to go out, but going to a hospital with new surroundings just makes them worse. So many people would be happy or would benefit from home visiting. And it has two roles: curative as well as preventive, rehab, and social. In the curative, you can do procedures. If somebody needs a bladder drainage Ryle's tube, this is already being done on a one off basis. And all you need is a good nurse who can do all this. Sometimes, if an old person has new symptoms, then a doctor definitely has to see the person. Sometimes it may be just a follow up of comorbidities, and you could have a nurse led prescribing team. A nurse can just go in, you don't need the doctor to go and check the blood pressure, and if it's all right, continue same medications. In many countries, a nurse is allowed, and physician assistants allowed, to continue existing prescriptions. But if there's any need for change, then of course the doctor has to be involved. Preventive, rehab, and social. So you have elderly people in the community who are quite well. You can go to their homes. It can be a lay person who can do the CGA. And I would like to make a pitch for the ICOPE. I hear there's very little mention about the ICOPE in this conference, but integrated care of older persons, which WHO has propagated from 2019, and I think still has to take off, which can be administered by lay people because it's so easy to screen in the community. This is not something we do in the hospital. It's more suited to the community, and you can have allied health people. You can give therapy, physiotherapy, diet counseling, etc., and of course, for elder abuse. So you see, home care, home visiting is very good. Now, in order to have this home care in a proper organized way, I have put in another thing called the integrated community based care. It's almost the same thing, except that you have a case manager. This case manager could be either a social worker who's specially trained, a physician assistant, or a nurse who's specially trained to understand old age problems, syndromes, falls, the whole thing that we talk about. And this case manager is like the puppeteer has so many puppets, of which the doctor is only one of the puppets. And he or she will decide which healthcare worker is best suited to this older person's problem. So you have an integrated. Now, this can be based in the community. So they do not need to come from the hospital. And I would like to refer you to PACE, which is a program of all inclusive care for the elderly, something which has been running in the United States in the San Francisco area with Chinese immigrants. And it has become a model in the United States. And they were able to take Medicare and Medicaid funds of these people. And because the financial model has to be secure, the state cannot fund all of this. And then in Japan also, there's a very good thing called I forget the name of the village exactly, where they saw that, but instead of getting one person at a time, if they had a case manager who could decide who would go, it was very useful. So we need to have community-based integrated care teams headed by a case manager who will send these people to the village, to the mobile health units. Now, we all know about these because of the stellar work of HelpAge India. But basically, you can have a lot of, either you can just have remote technology using app-based technology, smartphones, etc. The patient wears wearable devices, and personalized counseling, etc., can be sent, and the mobile team can come to them. But what we are more familiar with is an actual physical mobile unit consisting of a van with all the equipment, diagnostic units, surgeries, etc., will go like a camp in a central place, and the older people will go to this area. Now, this is what I mean. A mobile team goes, and you see it's a nice mail out here. These are obviously the well-off, the people who are not so disabled can come for their chronic non-communicable diseases, get their medications, and if they need a little lab tests, etc., it can be done. Now, the National Health Mission, which is now metamorphosed into the Ayushman Bharat, has also got mobile medical units, but it's not just for elderly. There are 12 thematic reasons why these mobile units have been rolled out, but care of the elderly is also one of them. And if you can see, these I've just put a few of the 29 states, and you can see I was not diplomatically correct, politically correct, and in not putting Kerala's mobile units of the health mission. But Tamil Nadu is first. I'm from Tamil Nadu, and I'm very happy to say that we have 1/3 of the country's mobile units. There are 1,691 medical units, far too little for a country such as ours. And it goes to so many areas. And you can see here that some of them are non functional, like the ones in UP. Kerala has 13, some for the tribal areas in Wayanad and other places, and they are doing a good job. But we need to enhance this so that it is only the government which can really bring up the in numbers and volume. Private units can only show the path. And these are corporate social responsibility initiatives by Wockhardt, Tata's, Bajaj Auto, etc. They've got these units. HelpAge India has the most and delivers to 108 districts in 23 states. So these people are just showing the way, but we need these people will be expensive. I mean, when it's a CSR, they probably do it very cheap, but we need to have the public health system go into this in a large way for community-based health. And the last thing is the hospital at home initiative, pioneered by Bruce and Leff at Johns Hopkins. And they said H&H is defined as a service which provides active treatment by healthcare professionals in the patient's home for a condition that would normally require hospital treatment. And they have worked hard at this from 1997. And it's not that we do not have hospital at home in various other parts of the world, but they documented it. They put down protocols mainly so that insurance would pay for it in the American healthcare system. So the prerequisites are that there has to be a daily nurse or physician visit. 24-hour availability of the nurse. Need not sit there, but availability. And there should always be an option to transfer back to hospital. And naturally, the person has to live near a motorable distance to the hospital. So these are the reasons why a person cannot be offered hospital at home. If there's hypoxic despite oxygen therapy, hemodynamically unstable, ongoing acute coronary syndrome, ongoing evolving stroke, severe mental state alteration, uncontrollable bleeding, fractures needing surgery. Obviously, for these, you have to have hospitals. But these are some conditions which which nowadays we do put into hospital, but could be have the option to identify them in the emergency ward itself, ER or the OPDs, and send them home and put them into a hospital at home. For example, deep vein thrombosis, cellulitis requiring IV medications, community acquired pneumonia, COPD exacerbation, acute febrile illness, and all those points. And this is just a picture to show you how hospital at home can be so nice. Even the dog is there, and the details are being vital stats are being sent, or instructions are being given to a patient. And here is an actual ICU bed, and the relatives are playing chess or something out there and having a good time while. So this is something which we can look forwards to. And this is one case which I myself did at hospital at home. A person with a stroke, completely bedbound, taught the patients how to write down the data, take a picture of it, and send it to me so that I didn't have to go every day and visited on and off. So, what do we need to implement community based care? We need to train allied health workers, large numbers of them. We need to create community based teams, multidisciplinary teams, and lay carers. And the business model has to be worked out, and we should have patient charters for fair, equitable, compassionate, and ethical treatments. And I just want to say that the National Program for Healthcare of the Elderly, NPHC, already has all this. If you go to this site, you will see there is on paper community-based primary healthcare approach is already there. Even in Ayushman Bharat, they have got domiciliary visits by a rehabilitation worker for bedridden elderly. They also want to train a multi-purpose health worker who will not be a qualified physiotherapist, this, that, and the other, but the essentials of all these multidisciplinary. So it's all down in paper in our public system, but I am pretty sure it is not functional. So it is up to us to make sure that we make it functional. So in conclusion, I would just like to rush through and say that hospitalization is known to have many adverse effects on the elderly. Community based care needs to be multidimensional to cater to all kinds of elder healthcare needs. And we need community based teams required for coordinated optimal care. National policies have to be refocused to the community. And the financial plans for community care in old age must be worked out for low cost care, not for profit profit reasons. Thank you very much. Sorry for exceeding our time.
Thank you, Alka ma'am, for your valuable insights in the field of this community geriatrics. As I also running the home cares in the Jubilee Mission Medical College, Thrissur, it's very useful to me also. So, as you all know, we will be having many questions. Due to time constraints, one or two questions is preferred.
I am Dr. Atul Kulsres from Agra. Ma'am, thanks for a nice talk, of especially for hospital and management of the patient at home and hospital care at the home. In Indian context, I think the provision of yoga and meditation is also important for Indian patients, just to decrease the stress level and increase the response of the drugs and the therapy. So, what's your opinion? It should be included or not?
I absolutely agree with you.
Yeah.
So when I say physiotherapists, I mean both trained in allopathic ways, yoga, all these things must be integrated because 3 or 4,000 years of knowledge of indigenous medicine and Ayush must be integrated. But the Ayush people must do new, well-tested methods of treatment. That's all I say.
Yeah,
but yes, I agree with you.
With yoga, do you advise for the meditation also? That is a very good, important for the healing process.
You mean
Meditation of any,
Ayurvedic medications?
no, meditation,
Oh,
meditation,
meditation.
prayer
Yeah.
and meditation.
Yes, all those things. But
Yeah,
where appropriate.
sure. Thank you.
Good morning. I'm Dr. Arora from Delhi. Ma'am, thanks very much for striking on the very basic need which is required for the elderly. And excellently, the model has been told to everybody. But this model may take, I think, many years to be implemented, to my mind, as far as India is concerned. I have been very intimately involved in the TB control program in the country. And I have seen from very close quarters. Immediately, I think three important areas required to be looked into. One, accessibility to the elderly, to the services which are already in place. And that's not really happening. Two, preventive part where early detection and care is really required for the elderly. And this is available, but still not accessed by the elderly. And third part, of course, which is very important, is the newer technology, which is really coming up, and its use particularly in care for the elderly. So I find in TB control program, we are looking at these three areas very, very intimately. And I think this is also true for the geriatric care. If you have any comment, you may tell. But my experience says the model which you are really advocating may be at this moment applicable in USA or Japan, as you had shown the slide also, but may take many years to implement. And government has really strategized to a greater extent to see that this model is being worked out because it not only involves effort by the healthcare personnel, but also a lot of finances, which I think government of India may not be providing. Thank you.
Yeah, I agree with much of what you say in terms of the TB. But over the last 2, 3 decades, India has made progress in handling TB compared to 1997. What I would like to say is we have some advantages which are actually rapidly disappearing. For example, the role of the family. So even we are now losing the family supports, but which I didn't mention here, home based care with some member of the family there can actually augment. I do not really agree that it will take years. All we need is a will, we need organizational capacity, and we need to train not doctors. We need allied healthcare. Allied healthcare is the answer to old age problems. It's not the doctors. So if you have an army of physiotherapists, dietitians, social workers, lay carers, not even nurses, we could handle looking after the elderly people with the advice of the doctor. Thank you.
The palliative care team has been doing this all over Kerala.
Due to time constraints, we are winding up session. Once again, thanking you, ma'am, for your valuable insights.